Chairman, thank you very much. And thanks for organizing committee for inviting me. I don't think my voice needs much of introduction. I'm the person coughing in the background, so just good for you to put a name on the face. That's me. I'm from, I had the pleasure to be Dr. Akbari's resident between 2000 and 2005 now. I'm a consultant surgeon in Westmead Breast Cancer Institute, which is the biggest breast cancer center in Australia. I'm also a clinical lecturer at University of Sydney. And I should I should also acknowledge my colleagues also being my mentor to participate in this research project. So I started with this case. Plastic surgeons and breast augmentation industry in general has done a great job in involving the patient in decision making. If this patient wants to have augmentation, she can see at least 50 plastic surgeons in Australia and ask them to try different type of implants, and she can see themselves virtually after augmentation. She can see herself from different angles, with bra, with clothes, even with different type of clothes. So why I'm interested in this, I'm not an augment surgeon, but I'm very interested in objectively assessing breast, particularly volumetric assessment. As an introduction, I go through this, why do we need to do, what's the current available techniques for volumetric assessment, how does 3D scanning work, and is there any way to validate this technique. This is a young lady presented with a large area of DCIS in the left breast. As we heard yesterday, there is an increasing number of demand or requests from patient sides to have bilateral mastectomy and reconstruction. She also had 2 children, and now she wants to be slightly bigger. So for me to go through the consultation, I use this. I assess her breast and I say, well, this is your volume now. How much do you want to be bigger? And I also show you, despite looking very symmetric, there is some element of asymmetry here, and we come to agreement and we can make a plan for her. This is not very complex because she's symmetric, and if I do nipple-sparing mastectomy, relatively same size, both, and reconstruct her with implant, again, same size, we should be able to achieve symmetric result. It is more complex. This is her result about 6 months, and she's now coming for having a lipofilling to correct this divot after about a week after operation. This is a bit more complex when I do unilateral. Then I need to create a breast which matches well with the contralateral side. So she's going to a theater once, and I need to get it right. I need to choose a proper implant to cover or to replace this volume removed from her breast. This is just a list of available implant, one type from one company, and you can imagine how many implants available in the market. But there is just one implant which is right for her and can create a perfect symmetry. So it's very important to get it right. Another patient, this time larger breast, happy to be smaller. She's got bilateral.